Ladies and gentlemen, a very good morning to all of you and welcome to this special session of Pink October 2024 Breakfast at UMHealth. We are delighted to have you as our gather to discuss and explore the advancement in the robotic surgery in breast cancer treatment. Today, as what we know, breast cancer remains a major global concern, and today's session will shine a spotlight on the cutting-edge development that are shaping the future of breast cancer surgery. So we are honored to have our two distinguished speakers here and at the forefront of innovation in this field. First of all, before I introduce our speaker, I'm pleased to introduce my co-moderator, Emeritus Professor Dr. Hoong from Biomedical Imaging Department in University Malaya, who brings with him vast experience in research and innovation. And Prof. Ng will be moderating this session together with me, and we look forward to an insightful as well as engaging discussion after this. So let's start. Let me introduce our first speaker here. Our first speaker, Assistant Professor Dr. Mok Chi Wei, also our alumni. He is a consultant breast surgeon from Changi General Hospital, Singapore. And Dr. Mok graduated in 2010 from our University Malaya and completed his general surgery residency in Singapore 2017. So he's specializing in breast surgery and has developed innovative, minimally invasive technique in breast cancer surgery. And Dr. Mok teaches at leading medical school, has published extensively, and is a co-author of a textbook of minimally invasive breast surgery and robotic breast surgery, together with Dr. Lai Hongwen from Taiwan. Today, he will share insight from the pilot robotic mastectomy in Singapore, PROSING-1 study, an initiative that is leading the way in robotic technology application in breast surgery.
Thanks, Prof. C, and thanks to the organizer for inviting me. Let me just share my screen. Again, thanks a lot for inviting me to share at Breakfast at UMHealth at your live webinar series. And Prof. C have introduced me, so I'm a proud alumni of UM. I'd just like to share on my study, a pilot robotic mastectomy in Singapore, PROSING-1 study. It is the first safety and feasibility prospective trial in Southeast Asia. So without further ado, I would just like to give a little bit of background on minimally invasive breast surgery. As perhaps most of you in the audience here would have known, minimal invasive or minimal breast surgery, the most common modality or path that we know is laparoscopic or endoscopic assisted breast surgery. And that can be further divided into the conventional laparoscopic instruments as well as robotic assisted breast surgery. But perhaps a lot of us would not have realized that breast surgeons have performed minimally access breast surgery for a long time, just that we don't use endoscopic instruments. For example, we use lighted retractors to actually help with access through a small incision. So that is also considered minimal access breast surgery. And a little bit about a background of MIS breast surgery in Singapore, if I may say so. I'm the first breast surgeon in Singapore to be trained in a full spectrum of MIS breast surgery. I did my fellowship from 2018 to 2019 in Taiwan. As Prof. C has mentioned, my mentor is Dr. Lai from Taiwan. And I came back in 2019 to Singapore. In August 2019, I did the first endoscopic mastectomy. So this is me with my mentor, Dr. Lai. We were doing an endoscopic mastectomy. This is back in Taiwan. So after that, as all of us would have known, the year 2019 and 2022, a lot of people would think that, their only memory of this period is COVID. But in fact, for my team and I think for me, these 3 years are actually very important years in what I call as laying the foundation for the future. In these 3 years, as we cannot travel out, I developed and further honed my skills in multiple different endoscopic surgeries, for example, endoscopic mastectomy, endoscopic breast conserving surgery. We even developed a new technique for endoscopic assisted ICG, in short, I call it EASY technique, EASI, for sentinel lymph node biopsy. And we also did endoscopic LD flap for breast reconstruction. And I have to say that I have to thank Dr. Lee, who is here also, our second speaker, because I actually went to her hospital and center to learn endoscopic LD flap for breast reconstruction. Then after that, we can talk about MIS breast surgery all day long, but I would just like to share with you, actually, not known to a lot of people, MIS or endoscopic mastectomy at the start actually went through a whole series of evolution, right? If we look at this flow chart that I show here, when we started with endoscopic mastectomy, the surgeons who started doing it first actually used just mainly retraction method, and subsequently other surgeons tried to improvise on the method by using insufflation with multiple port, like what we're used to in laparoscopic procedures. And after that, another group of surgeons started developing techniques using just a single port with insufflation. And I would say that it's a very important milestone, because from there onwards, actually, surgeons just move on to the robotic surgical platform by using the same technique for endoscopic mastectomy. So we may ask ourselves, or the audience that actually tune in so early might ask, why robotic mastectomy? In fact, that is the question that I was asked so many times after I returned from my fellowship. The first question is, of course, why endoscopic and not open? And then after that, why robotic and not endoscopic? So what is actually new in robotic mastectomy compared to conventional? As you can see here from the diagram as I've shown here, for conventional mastectomy, we can place our scar or incision in many places, but most of the time it is on the anterior chest, and it is in places where it is obvious. And why do we do so? It's because it is easier to access every part of the breast. So for robotic mastectomy, as you can see here, in figure B, incision number 7, this is the most, I wouldn't say all, but most commonly placed incision for robotic mastectomy, where we place it at the nipple-areolar complex level between the anterior to mid-axillary line, and the incision can range from 2 to 5 cm depending on the robotic surgical system and the port place used. So we have small hidden incisions. Of course, we expect excellent aesthetic outcomes, but I ask myself, as so much as to, I'm asked, is that all to it? So, of course, the answer is no. Robotic mastectomy has clinical significance that we can think of if we actually delve deeper into this. All of us know that conventional nipple or skin-sparing mastectomy has become the standard treatment for suitable patients in breast cancer surgery over the past 20 years. And while this technique provides satisfactory oncologic outcomes, it has its inherent disadvantages as well. There are some graphic images coming up. So for those of you who might not be prepared, you may want to, close one of your eye. So we know that, for nipple sparing or skin sparing mastectomy, because of the small access, sometimes excessive retraction, thereby disrupting the blood supply, you can have nipple-areolar complex necrosis or mastectomy skin flap necrosis. And all of us know when it happens, it is not good. And the rate of nipple-areolar complex necrosis is 2.1 to 7% in one of the systematic review and meta-analysis, whereas for mastectomy skin flap, it can go from 1.2 to 8.1%. And why we attributed that to the incision is because most of the incision for conventional mastectomy is placed around the areola or the nipple-areolar complex in order to hide the incision as best as we can. And because of that, you may have been going too near to the blood supply to the nipple. And this is just very logical to think about it. So when we have nipple-areolar complex necrosis or skin flap necrosis, it has a lot of implications. Distress. This can cause significant distress for the patient and surgeon. And it is strained to the resources. So we have patients with necrosis, sometimes of that a secondary infection. We need to use antibiotics. We need multiple outpatient visits for patient, and for some unfortunate patients, they may need to go for operative debridement. So all these are additional strain on the resources. And if we do reconstruction, there may be a higher risk of reconstructive failure For example, in implant-based reconstruction, it can result in prosthesis exposure, implant loss. And something that I always tell my juniors is that, think about it, we are treating breast cancer. When we have delayed healing, there is a risk that you are adversely affecting the patient prognosis because you actually delay the adjuvant therapy. So this is something very important that we should think about. It is not just about aesthetics. So then why robotic mastectomy again? Okay, this is a picture that I took from my book that I co-wrote with my mentor. You can see here, if I don't put any arrows, to a lot of you, this might be a picture with a ladies with the breast intact. And you wouldn't know that these ladies, in these pictures, all of them went through bilateral mastectomy, done through the robotic system, and with the implant reconstruction. And their scars are well hidden, either along the anterior axillary line, as I've shown earlier, or within the axilla itself. So what is more interesting is that when we look at the case series and case reports of centers who initially performed robotic mastectomy, why are the authors or why are the surgeons a believer of the robotic system? It's because in their series, and we're talking about countries who started doing and reporting their robotic mastectomy experience, and that is in France, Italy, Korea, and Taiwan, the nipple areolar complex necrosis in their cohort of patients are actually 0%. And we can see here compared to the conventional site, we have 2.1 to 7%. So if we can reduce the risk of complications to 0%, why won't we do it? And how is a 0% NAC necrosis even possible? I show you this picture, and I don't think this picture does justice, because for those of you who have actually looked through the camera of a robotic system, you will know what kind of visualization and the image quality that you get. But in this picture that I show, on the right side of the screen, you can see I've labeled the nipple areolar complex, and you can see the blood vessel supplying the nipple areolar complex. So in a robotic mastectomy, when I see the blood vessel, I can preserve the blood vessel. And with that, I can actually preserve the blood supply to the nipple. And the second thing is that because we avoid making a cut near the areola, making the cut near the nipple, we can therefore avoid direct injury to the blood vessels. As most breast surgeons present would know, sometimes before you could see it, when you actually make the cut and in the process of developing the flap, you would have encountered vessels, which most commonly would have to cauterize it in order to proceed with the surgery. So in a robotic mastectomy, because of how we place the incision, we can avoid it disrupting the blood supply. So before I started doing a study myself, I actually looked through all the studies. And as you can see here, we can see the powerhouses in this area are our colleagues from South Korea, Italy, France, and Taiwan. And of course, at the time, 2-3 years ago, United States started exploring robotic mastectomy as well. So I thought to myself, why not, in Singapore and in the region, we will add on to the available and growing body of evidence. So my team and I, we managed to actually complete our studies as well, a small one in Singapore, where we actually explored robotic mastectomy experience in women with breast cancer, as well as high-risk women indicated for risk-reducing mastectomy. So the history of robotic mastectomy started way back actually in 2014 and 2015, but the first paper came out somewhere 2-3 years later. And we can see these are the 4 pioneers of robotic mastectomy. And then over the years, a lot of our surgeons and colleagues like Dr. Lee herself in Korea and even Japan and Taiwan, they have started growing the group of surgeons who are able to perform and offer robotic mastectomy to suitable patients in their country. And of course, we're honored that in Singapore, my team and I from Changi General Hospital contributed to this in 2022 as well. So I'd just like to show, this is a very sort of outdated clip that I actually edited from the first case itself, just to show you what we actually see. And like I said, this would have done justice, but I think it's a good thing for those of you who have not seen before. And at the start, as you can see just now, we are doing an anterior skin flap dissection. And this is us doing a peripheral dissection, where we take off the breast of the boundaries of the anatomical landmark. And as you can see, shortly, I'm going to ask my assistant to actually gently palpate and press on the boundaries to show me. As all of us would have known, in a robotic platform, the surgeons are on the console away from the patient. And this is showing the dissection of the nipple areolar complex. It may look a bit bloody to you here, but just to make a note to say that when we dissect the nipple areolar complex, most of the time we don't use coagulation. We just use cold cut with the scissors in order to reduce further injury to the blood supply, as you can see here. So after taking down the nipple areolar complex, we will proceed with the rest of the dissection. As you can see here, this is the nipple areolar complex after dissecting it down. And we'll continue with the other side of the peripheral dissection. Sorry for the fast forward video, but as you can see here, the way the scissors and the bipolar forceps is moving is very ergonomic. So you can actually tackle extreme angles of the breast, especially over the middle aspect. After taking out the peripheral dissection, we actually dissect the breast of the pec major fascia, as you can see here. So after we dissect the whole breast, before we actually undock the robot, we ensure that we actually achieve hemostasis and to make sure that we're happy with the dissection. And we can undock the robot after that. Retrieve the specimen in its whole entirety. So we published our series, International of Surgery, somewhere earlier this year. As I mentioned earlier, we were happy to contribute to the growing body of evidence, as this study is the first in Southeast Asia and of course in Singapore. So we operated on a total of 17 patients with 29 robotic mastectomy cases. Sorry for the busy slide, I will summarize. The mean age of patient is about 54 years old. We can see that half of my patients in this series actually, the indication is for breast cancer, and another half with reducing mastectomy. Most of them had A to B cut breast, no ptosis, and we perform mostly nipple-sparing mastectomy. In terms of surgical, oncological, and post-op histology, I would like to bring to your attention on the surgical outcomes. We can see here the operative time are further divided into docking, console, and total operative time. The docking time is very decent at about 10 minutes across the whole series. This is the time taken to actually move the robot and place it on the patient before we start the surgery. And console time is the time spent on the robotic mastectomy. As you can see here, across the series is about 45 minutes. And the total operative time, 95 minutes. We can see here the average blood loss and length of stay in my series is actually very good. We have very minimal blood loss. And most of the patients, they stay for 1 day and they go home the next day after surgery. We have no conversion to open. We have no 30 days morbidity and complications. And with that, I'm looking at wound infection requiring intervention. I'm looking at flap and nipple areolar complex necrosis, post-op hematoma requiring intervention, and anesthesia-related complications. So they're all 0. When we look at oncology outcomes with good patient selection, I do not expect any margin involvement. Our mean mastectomy specimen weight is about 250 grams. That's about maybe a B-cut breast. And of course, I have to make a note to say that our follow-up duration is of course short. As this study, we aim to show and demonstrate the safety and feasibility of robotic mastectomy in our population. I would like to show this 2 chart, as I feel that this is very important to impress upon all of you here, is that in this study, I actually look at the learning curve analysis of this series in terms of total operative time and console time. You can see here, a learning curve analysis actually look at the time taken for the operative time or for the time to reduce significantly. As you can see here in figure A on top, this is the total operative time of the whole surgery. We can see here there's a significant reduction with the 5th case. And in terms of console time, that means the time taken for robotic mastectomy to be completed, it is even more impressive. The learning curve is the 3rd case. So I would say that this respectable operative time and the short learning curve could possibly be attributed to the fact that the main surgeon, that's myself, was trained and proficient in endoscopic breast surgery first before I embarked on robotic mastectomy. And I've assisted in at least 20 cases before embarking on my own case. And I would like to emphasize that I think this is a very important aspect of our training to see that, with adequate training and supervision, therefore, you can ensure excellent operative outcomes and a safe conduct of robotic mastectomy. So in this paper, we highlight that robotic mastectomy is safe, it is feasible, and in suitable patients with early breast cancer or those indicated for risk-reducing mastectomy. We contributed to current evidence that there's no major complications, morbidities, or conversion. And the last part, as I've shown earlier, with appropriate training, the learning curve can be short and it can still be a safe operation. So I asked myself after completing Promising 1, what is next? So now my team and I are currently in the process of recruiting for our second part of our study. This is called Promising 2. It is a prospective robotic mastectomy in Singapore study looking at long-term outcomes evaluations, and hope to be able to share with all of you in a few years' time. And also, we're in the process of conducting a cost-utility analysis of robotic mastectomy versus conventional mastectomy, and that's a gold standard. And again, I also hope to be able to share with all of you soon. Also, I asked myself, what can I do other than benefiting my own patients in the area that I practice? So we started in December 2022. With our colleagues' trust and help, I'm fortunate enough to proctor more surgeons. So in May this year, we proctored our colleagues in the Philippines to conduct their first robotic mastectomy in the country. And in August, we move on to Thailand. And my hope, and this is me, myself, in front of the logo. So I hope history in the making. I hope Prof C and her team will be able to perform their first robotic mastectomy soon. And I'm sure of that. And I think for starters here in the audience who may be interested to know more about minimally invasive breast surgery, you can actually get this book, and we give a very good overview and summary of what it is all about. And I think I'm coming to the end of my sharing. Thank you so much, and I'm happy to take any questions. And thank you again, Prof C and for inviting me. Thank you.
Thank you very much, Dr. Monk. Yeah. So, ladies and gentlemen, after the presentation for both our speakers, we will open the floor for a Q&A session. So please feel free to share your question and thoughts in our Q&A box there. Then we will start to our Q&A session later on. Yeah. Thank you very much.
And our second speaker, we have Associate Professor Dr. Jeeyeon Lee. 안녕하세요, Dr. Lee. She's an Associate Professor of Medicine at the Department of Surgery, Kyungpook National University, South Korea. Dr. Lee specializes in breast, thyroid, and robotic surgery, and is the co-investigator for the ROM trial, the KoREa-BSG 05, a prospective multi-center randomized control trial comparing robot-assisted versus open nipple sparing mastectomy with immediate reconstruction. Dr. Lee is a fellow of the American College of Surgeons, and she's actively contributing to medical education and research. Today, she will provide an ongoing update on trials in the KoREa-BSG, focusing on robotic surgery for breast cancer. And she has a wealth of experience in conducting and leading several clinical trials. Now let's listen and learn from Dr. Lee. Please.
Thank you for your kind introduction. My name is Jeeyeon Lee from Kyungpook National University Hospital in Korea. Thank you for inviting me in this great meeting, and this is my pleasure to introduce our clinical trials in Korea. So in Korea, there is a study group, the Korea Robotic Endoscopic Minimal Access Breast Surgery Study Group, aka KoREa-BSG. This study group launched at 2019, and up to now, there has been 6 times of symposium, and we have a lot of clinical trials going together. So today, I will introduce those kind of clinical trials. A total of 12 clinical trials are already finished or published or ongoing or the planning. So here, number 1 and 2 are already published in Annals of Surgery and JAMA Surgery, and from number 3 to 12 are ongoing now. So KoREa-BSG number 1 clinical trial was a kind of report of early experience in Korea. The title was a robot-assisted nipple-sparing mastectomy with immediate breast reconstruction with early experience in Korea. So study aim was to present the result of all experience of robot-assisted nipple-sparing mastectomy who underwent immediate breast reconstruction. From November 2016 to January 2020, we enrolled 73 female patients with 82 robot-assisted nipple-sparing mastectomy. At that moment, the 2019, at that moment, 11 breast surgeons performed robot surgery from 8 institutions, and 12% of cases were done by SI system, and 74% were done by XI, and there was only 2 cases were done by SB system. And now SB is more popular than XI or SI. When you look at the left side of figure 1, it was a 4 surgeons cumulative mastectomy time. Number A was obviously it was by Hyung-Suk Park. He had a lot of experience about robot surgery at that moment, and he has a shorter surgical time than the other surgeons. And B was Jamin Usman. He had 14 cases of experience at that moment, and his surgical time was decreasing according to the case accumulation. And C was mine. I had only 7 cases. And when you look at the right side, you can see the after 5 to 10 cases, the surgical time decreasing and looks more stable. So from this study, we could learn how many cases are needed to be stable or feel comfortable in robot surgery. So we published it in Annals of Surgery at 2022 with the KoREa-BSG name. Number 2 was Marcus study, the comparison of a postoperative complication rates between minimal access robot endoscopic nipple-sparing mastectomy and conventional nipple-sparing mastectomy. So PI was me and Hyung-Suk Park. Here we enrolled 221 cases of minimal access nipple-sparing mastectomy and 1,073 cases of conventional nipple-sparing mastectomy. In here, we define the minimal access nipple-sparing mastectomy includes robot and endoscopy. So totally 21 institutions provided the data for this study. And we found that there was no statistical differences between conventional nipple-sparing mastectomy and minimal access nipple-sparing mastectomy, both in acute phase, which means within 30 days after surgery, and also chronic phase within the 90 days after surgery. And interestingly, we found that the nipple areola complex necrosis were the rate was lower in minimal access and nipple-sparing mastectomy. We guessed that the reason is that the incision made far from the nipple areola complex. So here, when you look at the right side, the rate of complication, conventional group showed 34% of complication, but minimum access group showed only 32% in acute phase, and it was there was no statistical difference between two groups. So we reported this complication rates and the reasons why these are made in JAMA surgery very recently. It was October 2020. And fortunately, we could include our KoREa-BSG as a group author in this paper. Next, number 3 is a MORAS study. This is a prospective cohort study, which is kind of a registered clinical trial. PI is in Hyung Park, and the study aim is to establish a multi-institutional cohort to study prospectively for robot-assisted mastectomy for breast cancer. So Hyung Park made this kind of a web page. When you log in, you can see all the institutions. There are 39 institutions registered in this website. And we collected more than 5,000 cases of robot or endoscopy, as well as conventional lipospheric mastectomy. So we can take out the data from this website, and we can plan another clinical trials. So this is a very important one. And now Hyung Park is cleaning the data. So I guess, as far as I know, maybe by the end of this year, we can see the result from this clinical trial. And next one is on number 4 on BRCA study. PI is Jeeyeon Lee. This is oncologic outcome on lipospheric mastectomy and the preventive effect of risk-reducing lipospheric mastectomy in BRCA mutation carriers with or without breast cancer. So study aim was collect big data on Korean breast cancer patients with or without BRCA mutation. So we try to see the oncologic outcomes, and we try to compare the oncologic outcomes in groups who has BRCA mutation or not. Also in webpage, we collected the data for on BRCA study as well. And 21 institutions provided the data for this study. So this is a very brief summary. Now is submitted to some kind of journal, so I can't open whole research, but I can show you very brief ones. So 786 patients were enrolled for this study with 906 cases. Median follow-up period was 62 months, which is more than 5 years. And there were 120 cases of bilateral surgery. So here, when you look at the local recurrence-free survivor between BRCA mutation versus BRCA negative patients, there was no statistical difference between two groups, but negative patients showed lower local recurrence-free survivor, which means the BRCA mutation patient received the risk-reducing mastectomy. So when you look at this research, the contralateral breast cancer survivor was 0 patients who received the risk-reducing mastectomy. But when the patient didn't receive the risk-reducing mastectomy, it happened. Next one is wrong trial, which could be really important in medical field for robot breast surgery. This is a randomized clinical trial, and this was so difficult to design, but Hyung Park made it. And here the study aim is to provide the best evidence to date for the robot surgical system in breast surgery. So when you look at this plan, after screening of patients, we include only breast cancer. who doesn't involve the nipple or nipple-areola complex. And then we make a randomization. And the patient doesn't know which surgical method was done for patient, but after surgery, we can tell them whether the robot system was done or the open surgery was done. So here, there would be robot group versus conventional group, and you can find the whole protocols in clinicaltrial.gov. The number is NCT 05490433. So here, up to now, 192 cases are enrolled for this study. And our hospital also enrolled 6 cases for ROM study. And next is on BRCA2. As I mentioned, there is on BRCA study, and with the same data, another surgeon planned to make another study. So we call it on BRCA2. It is KoREa-BSG number 6 clinical trial. The study aim was to compare and analyze the differences in recurrence rate and survival rates between breast conserving surgery and mastectomy. And there is another study as well. It's about the statistical study, and we try to figure out which factor affect impactfully to the oncologic outcomes. So these are still ongoing. I don't have recent research, but as far as I know, they are very hardly working for this study. And the other one is on BRCA2B study. This is a next further study. The PI tried to identify the types and location of a BRCA mutation, which means locus of the specific in BRCA mutation. As you know, the specific locus are associated with a specific cancer, like ovarian cancer or breast cancer or pancreatic cancer. So we are trying to figure out which focus is the most focus in Korean patients who has BRCA mutation. And next, number 7 is Proto study. This is the comparison of learning curves between surgeons who are in frontier group and second mover group. I am the frontier group, and there is a next generation who performed the robot surgery, and they learned these kind of techniques from frontier group. So we try to compare learning curves and surgical times and troubleshooting method and so on. So still it is ongoing and we are analyzing. And next clinical trial is number 8. We call it RBCS. It is about the robot-assisted breast conserving surgery in Korea with a multi-center study. So here, the study aim is to conduct a multi-institutional study, patients who underwent a partial mastectomy using robot-assisted surgical method. I don't do the robot breast conserving surgery, so I didn't have any data for this study, but there are 8 institutions that they performing the robot breast conserving surgery. And next one is Sprout. This is the study that surgeons who only use the SP system. So the title is a single port robotic mastectomy, unveiling all the outcomes of a new technique. So when the surgeons uses the SP system, they can register and they can enroll the patient for this study. We are trying to look at the post-operative adverse events and recurrence pattern and symptoms and preoperative examination for recurrence and survival outcomes. Okay, number 10 clinical trial is now we are moving to AI. As you know, AI is a very hot field in medical field. So we are trying to make educational video clip from the surgeon's video clip. So here, Hyung-Suk Park and Jeeyeon Lee, they try to collect all the video clips from the surgeons who perform the robotic breast surgery. And usually it is coming from the MARES study, which is number 3, and a ROM study, which is number 4. So after they collecting all the video clips, and the AI will learn, and they're gonna train all the video clips to the AI system, and then we can make a very standard and good educational video clip. So this is our 10th clinical trial. So on September, we had a 6th KoREa-BSG symposium. We are still work together and discuss, and we are go through the troubleshooting, and we can help each other. If there is a surgeon who really tried to robot surgery at the first time, we visit that hospital and help them to make it better surgery for patients. So thank you for your attention, and if you have any ideas working with us, please let me know. Okay, thank you.
Yeah, ladies and gentlemen, we are now moving on to the Q&A portion of today's session. This is a great opportunity to engage both our speaker here. So if you have any question, please feel free to raise your hand, or we will bring a mic. We will try to see from the Q&A chat box here. To kickstart, I would like to let Prof. Ng to start the Q&A.
There are a couple of questions that we have received. Let me start with the first one. Beside the Da Vinci, that is, well, most well known, we also have other robotic systems, various brands such as like the Hugo, the Rosa. So the question asked is, are there other manufacturers or models for robotic breast surgery?
Okay, I'll answer first. In my hospital, we have SI and XI and SP. We have 3 of them. But as you know, SI device did not, it's intuitive, they don't produce the device for SIS more. So we need to stop using SI, and we are considering to buy Hugo, or maybe Intuitive can change SI to XI system. So we're considering.
Okay, how about Singapore?
Yeah, hi. Thanks for the question. And just want to add on to what Prof. Lee have just said. I think in Singapore currently there's only Da Vinci. Hugo is in, but they are still engaging the rest of the hospitals. And the problem with a robotic system is that because of the cost, the initial cost involved. So I think most hospital will start with what system they have. And in my hospital, it's Da Vinci, and the same for the rest of the hospitals in Singapore. As to whether it is possible to use some other robotic system to do breast surgery, of course it's possible. And in fact, I'm actually quite excited with some of the other system where they may actually address some of the issues that even though robotic system is good, but there are still some of the issues. I think Prof. Lee would agree that when we do the surgery, there's still certain parts of the system that can be improved. And then I think that is what the newer robotic system brings into the market. And yeah, but for now, almost all hospitals in Singapore only have Da Vinci. Yeah.
Okay, thank you.
Yeah, my turn now. Yeah. Thanks a lot for both of you. Really have to wake up so early and give us all this sharing, which is so impressive. Yeah. So now I just want to direct the question to both of you. How do you both see the role of robotic surgery evolving in the next 5 to 10 years, particularly in the advancement like AI, virtual reality, all that in Asia and Southeast Asia?
Well, in my opinion, robot surgery, I think in the future, we don't need to discuss about the robot surgery. It could be a standard surgery because still now many surgeons need to learn the new surgical technique. It is really hard, especially for the senior surgeons. But in next generation, they will learn when they were in residence, and it is very familiar for them. So I guess a robot or endoscopic surgery will be a standard system, and maybe one day we need to learn open surgery. Yeah, that's my opinion.
Yeah, I totally echo what Prof have just said. On top of that, right, I think if you ask me, if we take the cost out of the picture, which it will be in years to come. I don't know how long, and I agree that robotic surgery should become the standard for breast cancer surgery or even other surgery. And the thing is that we are seeing more and more benefits with the robotic system. And I think one thing that both Dr. Lee and I have not shared is on longevity. I said longevity is longevity of the surgeon. For those of us who know how to do conventional nipple sparing, you know how difficult it is. You know, sometimes you can get a very bad occupational hazard. You get neck pain, wrist pain while trying to visualize through a very small cut. And I said longevity because not only robotic surgery, endoscopic and robotic surgery are able to allow the surgeons, hopefully, Dr. Lee and myself, to operate way into our 70s and 80s. So I
Yeah.
think this is just one of the benefits that, normally people don't look at surgeons' benefit. And you can see what Dr. Lee and I have shared with what KoREa-BSG is doing. We are looking at patients' outcomes. But I believe after looking at patient outcomes, we will looking at other outcomes, and we'll all be convinced that MIS breast surgery and robotic surgery is the way to go forward. Yeah, that's my thought.
Yeah, I really agree for that because 2 hours of endoscopic, your hand is really cry and bad. But robotic, even 3 hours or so, our hand is so well. I think the other portion or the other parts of looking into the ergonomic portion of the surgeon or operator is also very important here. Yeah. So I would like to let Prof Ng to continue the Q&A.
There's another question that came is interesting. The question is, how is the financing of the robotic assisted breast surgery in your country, and who pays for the operation?
Well, in Korea, actually, the for the cancer patients, the government insurance is really perfect. They provide 95% of all their payment, but for robot surgery, this isn't new, so they don't pay for this. So the patients has to pay by themselves, and it is about 10 million.
Yep, same for Singapore. Our national insurance pays for the surgery itself, but the consumables with robot, patient pays for it. So it's like a co-payment system. But we are trying to convince the government, not an easy task to do, to try to think of a reimbursing for the robotic surgery. And then with that, my team and I, we are currently working on a cost utility analysis to see whether, can we prove the cost effectiveness of robotic mastectomy. And I think I'll be more than happy to share with all of you when we have the results. Yeah, because I think that will push things forward. Yeah.
What's the average cost in Singapore?
So if we are talking about patients who are already subsidized, they pay about 5,000 to 6,000 Singapore dollars extra on top of what they would have paid for their surgery. And I think this is about the same when I ask my colleagues in Taiwan. That's the extra amount that in Taiwan they're paying as well. So I think in most countries, it is still like a co-payment like Korea and Singapore as well as Taiwan. Yeah.
Okay, thank you.
Yeah, we have a question from Professor Ong. He's the robotic, our urologist that leading our robotic team in University Malaya. And Prof. Ong would like to know, when can robot perform the surgery autonomously and independently without human intervention? What do both of you think?
It might be a little bit risky because we have to judge whether this area is a nipple or we are close to skin. You know what? I have several complications. When I was doing robot surgery, I punched out the skin and then the, you know what, CO2 gas just leaked out and the skin was shrinking. So if I wasn't there, I didn't handle this kind of thing. Maybe robot system can't handle, and even it can't recognize this is whether this is a complication or not. So I disagree this kind of surgery.
I think for me is Prof. Ong's question is very good, right? When can robot perform surgery? I think in one day this will happen. But I think just on what Dr. Lee have mentioned, right? I think it's a safety net. If we are going to get the robot to perform the surgery, what is the safety net, right? And how can we allow the robot to do this, knowing that if something happens, like what Prof. Lee mentioned, if there is a complication, when can the robot, intervene and put a stop to it? I think if you ask this question, it's a very open-ended question. It's definitely possible in the future. But one thing is, how are we going to embark on this? And like what Prof. Lee said, should disagree. For me, I would see what the system can do. But I feel that, it's either the robot become the first line and the surgeon as the second. And then you see what the robot can do, right? But because if not, I think it is a little bit hard in healthcare to actually tell the patient that, look, your surgeon is going to be the robot, it's not the human behind. Yeah, that's my thought. But interesting question.
Yeah, I think the consent will be a little bit difficult. The robot might need to sign the consent together with the patient. Okay, so with the time concern, we have the last question for both of you. As what we know, education and training are very critical to the success of new surgical techniques like this robotic surgery. Yeah. Could you both share your insights on how we can improve training and education for future surgeons in robotic surgery? Probably we are not talking about, regional as well as globally, particularly in country where access to advanced technology may be limited. Yeah.
Actually, as you know, the FDA didn't approve this robot surgery yet because we don't have much sufficient oncologic outcomes for breast cancer patients. So if the surgeon who is not trained much for robot surgery, it might be really risky and unethical. So, in my opinion, the government need to make the effort to make the certificate for this kind of robot surgery, or the cancer society they can make. So, in the future, maybe we need those programs, and also for the surgeons who try to robot surgery first time, someone need to help not make any harm to patients. So we need mentors.
Yeah, totally echo. So I think what Korea, our colleagues in Korea, like KoREa-BSG is doing is very good. How can you improve on education and training? You share your results, you share your experience with people. And I'm personally, for myself, I'm so thankful to Dr. Lee, and like she said, a lot of mentors. In fact, I have a lot of mentors. She's one of them. So I think in our career, it's so difficult to just do your own things and be in your own circle. And from where I come from, Singapore is very small. is a little bit hard. So I learned from mentors like Dr. Lee, Dr. Lai, a lot of mentors. And I think that's very important. And as we come back, when you learn already, you shouldn't be shy or you shouldn't be stingy not to share. So like what we are doing today, and I think Dr. Lee would do the same. She shared a lot with me when I was much junior. And so now, like we share in this platform, and going forward, other than sharing through webinar like this, when we organize courses, we organize workshop, and that is also part of the education. And that as this goes beyond your own institution, this goes beyond your own country. You are sharing with the region, you are sharing internationally. And I think this is a way to rally everyone together so that we can do things together. And I think like Dr. Lee and our colleagues in Korea, they see this much earlier. They started in 2019, but there's no too late. That is never too late. So we may start later, but we can all come together. So I think that is the way, if you ask me, to push this field forward. Yeah.
Yeah, thank you very much. I also echo both of your thinking and thoughts as well, because it's not easy to pioneer the advanced technology in the country, because sometimes we do think more advanced, but a lot of things we also need to think of, like patient safety and other parts like oncological outcome and cosmetic outcome as well. Yeah, but with the gather as well, collaboration with other teams as well as other countries doing the same, having the same vision, I think that will come true. Am I right? Yeah. So I think our time is very, very short. I'm so grateful to have both of you and my co-moderator with me and my supervisor as well. As we conclude, I want to sincerely thank Professor Dr. Mo Chi Wei and Associate Professor Dr. Jeeyeon Lee for their excellent presentation and the insights that on robotic surgery in breast cancer shared with us. And your contribution today have been truly enlightening. So a special thanks also to Professor Dr. Ng for co-moderating this session with me. And thank you all for your participation and a thoughtful question as well. And let's continue to innovate and collaborate in the fight against breast cancer. Enjoy the rest of Pink October 2024. Thank you very much, everybody. Thanks a lot.
Thank
Thank
you.
you.
Can we have a